Welcome, everybody, to the Global Spine Initiative podcast. I'm here joined today with spine surgeon, Dr. Paul Slosar. My name is Dr. Gurtej Singh, and I'm an advanced interventionalist in the field of pain and spine. Today, we're going to have a quick discussion regarding degenerative scoliosis in adults, the injections, the non-surgical treatments, as well as when's the right time for me to suggest a patient go see Dr. Slosar for definitive treatment intervention. Paul, it's great to see you. Thanks for joining us today. How about we kick it off? A lot of times patients first end up in the hands of a surgeon when they have any kind of a pain or spine pathology. How do you know when the right time is to send them over to an interventionalist, or when's the right time just to get them into the operating room first?
Yeah, no, it's great to be here, and just a quick plug to the GSI, the Global Spine Initiative. I believe this is a incredible and opportunistic time to be talking about this. There's so much overlap of thought processes, technologies, and ultimately the idea of trying to get patients the best relief possible with the lowest footprint. Sometimes that is surgery, and many times it's not. I like the idea of these dialogues, and just as background, I was very fortunate in our practice, and I was trained in the practice I ended up practicing in. We had in our same practice sophisticated interventional spine specialist, Rick Derby, one of the most famous spine injection docs on the planet, was one of my partners. So, it's not a foreign concept for me to think the first thing that patients who have a degenerative scoliosis or a curve, that's essentially what this means, to be evaluated and treated first with my interventional colleagues. And so from my perspective, and I think I do speak for the mainstream surgical community here, would be most of the time adults with scoliosis, it's a pretty big undertaking for the surgical side of this. It's very much a reconstruction, as it said, versus a small, minimally invasive surgery. So the onus on the interventional pain management doctors to try to help avoid that is even higher, I think, than some of the smaller surgeries where we might just think, well, it's not as big a deal. So I use, and I'd love your response to this, Gurtej, what I have used in terms of my relying on my colleagues who do the spinal injections and therapeutic treatments is sometimes I need your help to figure out what's the most symptomatic place in the spine, what's hurting specifically, and targeted spinal injections can be helpful. And then sometimes I'm just sending you for therapy. I'm just like, hey, and very much the patients would like to go see you first. So I'll toss it back over to you, and maybe you could kind of touch on how either they're referred in from somebody who knows what they're doing, or maybe they come straight from a primary. How do you assess these patients?
So, as you would, right? A proper history, a proper physical exam. For me, I'm always trying to tease out how much of this is maybe more mechanical and axial in nature. So pain that's just in the back, or maybe the back into the upper buttock, versus a true numb, tingling, burning pins, needles, sort of what we call sciatica, where it's shooting all the way down the leg following a particular dermatome. So once we can sort of tease that out, then that really helps the patient understand what the next sort of series of algorithmic pathways that we follow. PT is by far and away number one. When you have a good physical therapist who can help a patient not just simply fix their core strength, but again, with these scoliotic curves, they're going to need to fix certain areas in one direction and certain areas in a different direction. And so I know a lot of times patients get frustrated with physical therapy. It's the ones who stick with it and do their home exercises every day. They have the success, and the success is there to be had with PT. But then once that doesn't exactly solve the issue, it's where you have to start to tease out from that patient. Is this something that we're going to do some mechanical blocks, or we call facet blocks, in the back of the spine? Those tend to lead to rhizotomies or nerve denervation procedures to kick the can down the road while they continue to strengthen their back. They're just getting less back pain while strengthening. The tricky part are the ones who start to have the numb tingling down the legs, where their gait is disturbed. They're needing to use a cane or a walker.
Yeah.
They have a slappage gait, so you and I have heard this, right? You can almost hear them coming down the hallway because
Oh, yeah.
one foot just slaps every time that comes down. And there you're just teasing out the dermatome. If there's somehow a way that I could do a nerve block injection or an epidural injection with some cortisone, give them a few weeks or months of relief, then it might help you as a surgeon know maybe I don't have to go in and reconstruct everything, but I might be able to just relieve a little bit of stenosis and narrowing, for what's
Yeah.
symptomatic.
Yeah, I totally agree with all that. I would say, from my personal experience, if I can, see the patient's scoliosis, which we usually can in these adults, it's usually not subtle or their kyphosis, they're bent forward. The therapy is often, I know we often have to do that, but a lot of them have had, a few rounds of that. So I've often tried to, quickly get them in the best case scenario to somebody like you to maybe help jumpstart the therapy if that's a possibility. But here's what I would like to say, and it's always difficult, knowing who's going to be listening for our podcast. You have people who have highly sophisticated training who do nothing but spinal care, surgical or non-surgical, and then you have maybe people who are in primary care or people who are just non-medical. But in terms of what I usually tell my patients, because a lot of them are like, oh, is that going to waste my time? Do I have to go through this? And I usually tell them, I think it would be effective because you can only do so many injections, right? There's only so much time allowed and there's only so much cortisone, et cetera. But I usually tell them, if we can get if the injection, the interventionalist can help get your pain, relieved by anywhere from 30 to 50%, which is usually from a clinical perspective meaningful. And if it lasts for anywhere from 2 to 3 months, I usually say I would continue that kind of, as you said, algorithmic treatment with somebody I trust. Do you have a different standard? Or how would you view that? Because I want to tell them the wrong thing and then I set you up for failure.
Oh, yeah. So, the difficulty is I think clinically, from a patient's perspective, many of them just say, Doc, I'll take whatever improvement you can give me. Unfortunately, our insurance system at the moment, sort
Yeah.
of almost mandates that if a patient is not getting more than 50% improvement for more than 4 or so months, it's sometimes difficult to get that
Yeah.
second injection approved and authorized. So you have to go back and you have to fight for the patient and work through the denials to try to
Yeah.
convince the insurance company, look, clinically it made a huge difference. So a lot of times we'll add metrics like an ODI and some of the other questionnaires to sort of show the insurance company, hey, look, before we did the injection, they were at this level. After the injection, they may not say they're at 50%, but clinically they are showing
Yeah.
more than 50% benefit. So yeah, nowadays the magic word is 50%, and the magic time frame is typically 3 to 4 months. Most insurance companies will allow us to offer the injections typically 3 times a year. In that first year, we might get away with a fourth one because you're trying to sort of kickstart
Right.
and get them downhead in the right pathway. And there's typically a lot of inflammation, right? In that the first time that the patient comes in, the degenerative process has been ongoing for years, but there is something, that has kicked off inflammation that really drives them to come and see us. So
Yeah.
for that first year, we might get a fourth injection in, but long term, you're looking at 4 months and about 50% improvement. It is the hardest question that we have to sort of answer and navigate for our patients because ultimately, we do know that surgery tends to be the fix. And so how much is the patient willing to help kick the can down the road also plays into what we do.
No, and you bring up a good point that, you can have not only the patient in front of you who has a certain set of fears and expectations, but then you've got the hidden family, friends, person they met at the grocery store who has a lot of free medical advice, be it pro or con, especially toward the surgical side, and the miraculous treatment they had with some secret injection that their person did with something, that we've never heard of. But that being said, we sometimes are thrust into the role of saying, hey, it's reasonable to apply some objective measure of success because the desperation of the patient sometimes can interfere with their ability about, what to do next, I think, for sure.
You're right, and the difficulty is understanding and sort of managing the pain expectation versus the dysfunction that's happening, right? I think from a surgical perspective, and like you've had the privilege of working with some amazing interventionalists, I've had the privilege of working with some amazing spine surgeons. Helping a patient to
Yeah.
understand what the right expectations are after surgery really make it easy for us, right? So if we can say, Mrs. Jones, we can see right now, yes, you have a lot of back pain. Yes, you have sort of pain and weakness going down the leg. We can be pretty confident that the pain and the weakness down the leg is going to get much better. The back pain is still going to need some time, some continued injections, rhizotomies, maybe even some pain medication, because so many patients come back or, again, hear from friends,
Yeah.
spine surgery didn't work. And when you tease it out, you realize, oh no, my leg is working again. It's my back that hurts. And I'm like, well,
Oh
but you
yeah.
got
No, the
things to get there to open things up, to make the nerve work. And
No, the moving goalposts is it's obviously an issue that we all have to navigate, but I do think actually the topic that you and I have been given to talk about, adult degenerative scoliosis, again,
right,
for the people who don't, know instantly what those words mean, we have almost, as this conversation topic for the podcast, it's one of the more studied and more specific categories of things versus low back pain. No one kind of knows exactly, or discogenic pain, et cetera. But you brought up a good point earlier that is very tied into degenerative scoliosis in adults, is the issue of, are they compensated functionally, decompensating, meaning that even if they don't have all that much pain, many of them have self-limited activity to control the pain, but their exhaustion level, their posture is bent over. They're in the grocery store on a cart. They are becoming globally dysfunctional, like their heart, their lungs, et cetera. And there is a certain issue of them being lost, if you will, maybe in an interventionalist clinic that isn't as scrupulous as yours and doesn't apply the same standards, or have the same relationships with surgeons. Maybe you could just talk about how, when you start seeing patients who are really, you know, decompensated, as it were, meaning, even if they're not in all that much pain, how do you approach those patients?
these are the most difficult type of conversations that we have to have. I mean, as interventionalists, we see patients over and over again, whether it's prescribing medications or following up from physical therapy or even just following up from various injections. So we get many touch points, with these patients. We can visually
Yeah.
just see the decompensation happening.
Yeah.
They've gained so much trust in us. Sometimes they just say, well, Dr. Singh, you please do the spine surgery. And no, 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 no,
We'll come back to that in a minute. That was my bad question to ask you, but go
no,
ahead.
wrong, wrong hands for adult degenerative scoliosis. So you have to, like both of us have been privileged, right?
Yeah.
In our work environments, you have to have a spine surgeon who you can rely on, even if it's you telling the patient, hey, I just want you to go have a conversation with them.
Yeah.
Just because you go and see a spine surgeon doesn't mean that they're going to hold your hand and put you on the operating room table that afternoon. And I think sometimes just the notion of seeing a surgeon scares a patient. And I think that's maybe the one great take home point
Yeah.
for all patients who are listening to us today. Please don't be scared that we're going to force you into anything. At the end of the day, patients have their jurisprudence to make their own medical decisions. We hope that together we make the right decision, and ultimately patients can choose to have injections or have surgeries on their own. Knowing
Yeah.
multiple opinions. And I was just going to say one last piece, right? Your education and background and understanding and literature reading that's brought you to where you are today is different than what I have had and done that's brought me here today. Yet we sit here almost touching in terms of how to help a patient. And I find when I tell patients, no, 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 I want you to go see my partner. He might have a completely different vantage point. And they look at me, they squint their eyes like, what do you mean? You're both
Yeah.
spine
That's a great
specialists.
point.
Yes, we are both spine specialists, but we come to this together in from different pathways. And so there is
Yeah.
something that sometimes my spine surgeons see, then just Gurtej, you missed this. They should let's go do that. So,
Well, and you do bring up a good point that, and I always have to remind myself, like, we were talking about earlier, that I kind of grew up in an integrated clinic that has, had collegial relationships. And I think sometimes patients and even their primary care doctors view us as binary, like you either go to pain management or you go to the spine surgeon. And many times I'm like, well, wait, we need to integrate the information we get from our interventionalists into our treatment plan. Even if it's just a matter of saying we tried it and it didn't work. But very commonly, I will use the information. I will send you or my interventionalist a note very specifically. I need the L3-4 and L1-2 nerves blocked. They're confusing me. I don't know which one's causing the
Perfect.
majority of the symptoms. And somebody who can do that injection capably and not take what I said and throw it in the garbage and just do a bunch of other sacroiliac joint injections. I had that happen. I'm like,
Yeah.
I didn't order that. He's like, well, I thought that's what was hurting him that day. I'm like, I'm trying to figure this out. So the idea of the Global Spine Initiative trying to foster this idea of this interrelationship between the two disciplines that both actually contribute to the betterment of the patient. But those of us who do use this kind of information, we integrate it into decision making. And like you said, we can sometimes then offer a patient a smaller footprint surgery than maybe another surgeon who doesn't use these kinds of techniques might offer them.
That's well said, Paul, and very true. I certainly have at times struggled when, I get a referral from a spine surgeon that says, inject this, and I'm scratching my head. And, the ones who I have great relationships with, I go, look, we're going to do what, Dr. X has asked to do. Let's see how it works. If
Yeah,
it does, great. Now we've got a solid answer. All three of us can work together to get the patient the right solution. If it doesn't work, hey, Dr. X and I have a great relationship. I'm going to text him. I'm going to let him know that it
exactly.
didn't work. And I'm going to tell him, hey, what do you think if I instead do an SI joint injection? And so,
No, yeah, that kind of, and prior to the availability of the kind of instant messaging that we can use today, it was very cumbersome. You'd call, well, Dr. Singh's in the injection suite. He's gowned up. I can't like talk to you, or they could hold the phone. But I sincerely would keep a little note. I would ask my scheduler, especially it's the 1 in 10 patients where I'm really like, oh man, I need some help here. I would say to them, put it on my schedule when that patient is booked at your clinic for the injection, and I'll try to get at you the day of and just say, hey, because even if you and I talk in like a minute, you can get so much
always.
more color on what I'm doing. Where if we can't communicate it, it certainly puts a much higher burden on you to try to, blindly go where we're asking you to go with no input.
Yeah, of the many goals that Global Spine Initiative is setting out to accomplish, one is absolutely better communication between spine surgeon and spine interventionalist, and education to the patient. Hey, do try to
Yeah.
seek a surgeon or an interventionalist who work with the other. And that doesn't necessarily mean you have to be under the same roof like the two of us have been privileged to have. Many colleagues have
Yeah.
wonderful surgeons and they just work in different practices, but they're otherwise so collegial and put the patient first. And that's where patients should understand. That's what Global Spine Initiative is trying to do. Is
Yeah.
trying to say, here are some brilliant spine surgeons, here's some brilliant interventionalists. How do the two of us put the patient first?
Yeah, I love that. I don't think we could end on a better note, trying to model this behavior and these conversations that we're all having in different topics about how the two disciplines are working together to bring awareness and even just sometimes give some of our colleagues a blueprint. Like this is kind of as simple as it works, and you do have to put a little effort into it. But I really appreciate the chance to have chatted with you today. I hope everyone finds this interesting and pay attention to Global Spine Initiative. We're going to be here for a while, and I hope we continue to have more conversations. It was a pleasure today, Gurtej.
Thank you so much, Paul. And again, please do follow our other podcasts here at Global Spine Initiative, and certainly our website so you can access all the full resources that we take care.
Great. Thank you.